Today's talk is going to be sort of a little bit of a hybrid, mainly talking about colon cancer, metastasis to the liver. The same thing could be said about hepatocellular cancer, gallbladder cancer. But the bottom line is, from all this, is the diagnosis of metastatic colon cancer, breaking it down into resectable or unresectable. The unresectable lesions now, with the better chemotherapeutic drugs, with the Surtec beads, many of these patients that we can take from unresectable to borderline or potentially resectable to resectable and provide a cure in these patients, a chance for cure. For instance, colon cancer, the majority of patients that present with unresectable colon cancer, metastasis to the liver, we can downsize a fair number of those, and then with resection, cure rate on those can be as high as 40% overall disease-free cure rate, and overall survival can be quite high, 10 to 20%, in patients that, you know, as few as just a few years ago were considered completely incurable. Oftentimes we see patients that have either primary liver tumors or metastatic disease from other tumors, so cancer that starts in the colon and then goes into the liver, that are alive, as we heard in this story, a decade later. So it's really very heartening to see the progress that's been made in this field over the past decade. Definition of surgically resectable hepatic metastasis, same thing could be for metastatic disease. We used to consider basically if you had more than 4 lesions or a lesion greater than 5 centimeters, this was something that we could not provide a chance at surgical cure. What we do know now is that basically if we can get the tumor out, no matter how many lesions, if we can provide the patient, make the patient disease-free, even if they have lymph node metastasis adjacent to the liver, then we can provide those patients with a chance of cure. And the goal is to be able to get the cancer out while leaving enough liver in place that the patient can survive. And that's about 20% liver. Liver is an amazing organ from the point of view of regenerative powers. The Greek myth of Prometheus, who was chained to the rock for stealing fire from the gods, and the eagle would fly down every day and devour his liver, and by the next morning his liver would have grown back. Well, there's a little bit of truth to that. If you do a liver resection and you take half the liver, that liver will be regenerated to the same size within a 3-week period of time. So it's a remarkably resilient organ. Determining resectability, basically we now have such great technology, which we didn't have before, as far as being able to determine how much liver we're going to leave based on the CT scan, measuring volume, and also the technology with intraoperative ultrasound, where we could determine where the lesions are to guide resection, plus with devices and monitoring in the operating room that obtain hemostasis or controlling blood loss. That two things, we can do a lot of our operations now that we couldn't 15 years ago, and we can do them safely. Operative mortality or death associated with surgery, very, very, very uncommon. And recoveries are quicker since we do many more of these operations laparoscopically than we did before. So a lot of them are done minimally invasively, recovery period's quicker, plus we can do more operations and do a better job of determining who we're going to operate on beforehand. Busy slide, you'll see a lot of that today. I like to pride myself on busy slides, but the bottom line is we want to carefully stage the patient, oftentimes using PET scan to determine along with the CT scan. PET scan, for those of y'all who may or may not know, a radioactive glucose is injected into the patient. Tumor cells are hypermetabolic, meaning they're working hard. So they take up that glucose. That's what they're going to metabolize, so it shows up as a hot spot on a CT scan. And what we want to do, if we're going to surgically resect a liver, we want to make sure we don't have disease anywhere else. So we can do a better job of selecting patients both with better CT scan and PET scan as far as determining who has cancer in the liver or or surrounding lymph nodes. If you have patients that have a lot of disease outside of the liver, then doing a big operation is something we want to avoid, and all the technology helps. And this is the liver. Pretty exciting stuff. If you're me, if you're not me, it's probably not that exciting. But the bottom line is what we want to do is the liver has a blood supply, dual blood supply actually. It has an artery that goes to it and a vein that goes to it, and it branches and goes to the right side and the left side, and then it is drained by 3 veins that go into the largest blood vessel in the body, the inferior vena cava. So we want to be able to get the cancer out while leaving blood supply coming to the liver and going out of the liver. So that if we can do that, then we can leave as little as 20% of the liver behind. And when I was a resident, which doesn't seem that long ago, but it was, we just would hardly ever operate on the liver. But now at this point in time, we very seldom have problems post-operatively with these patients compared to vis-a-vis, say, esophageal surgery. Recovery periods seem to be much quicker, complications rate lower. Thank goodness the liver is a remarkably resilient organ. And with colon cancer that's metastatic to the liver, if we can get it out and we can get a clear margin, the cure rate is very high, as is the disease-free survival. Or what I consider very high. I do mainly GI surgical oncology. We have patients, many patients, 40% of our folks that we're able to provide do R0 resections, meaning we got the whole tumor out, that are alive up to 10 years afterward. And I think that number is going to go up. I mean, the bottom line is we need to remember that as we're going along now, it's almost every 6 months or a year now we have another modality that comes along that boosts things up. So eventually, hopefully with this disease state, we get to the point where it's almost a chronic problem. And right now, just sort of treading water with some patients that even have recurrent disease with the Certix beads and whatnot. Again, this basically, good job on the busy slide, but the take-home message on this is we very rarely have operative deaths associated with this. I guess it sounds a little blunt talk. I mean, this is usually a talk for medical people, but operative mortality, chance of doing in with surgery is probably around 1%. Really, the only time we have any trouble is when we are pushing the edge of the envelope, if you will. So you have somebody that the only way you can get the tumor out is you take them right to that 20% of liver, or you're going right to the edge of leaving outflow or inflow, vascular supply to the liver. Most of these aren't that way, and it's pretty straightforward, 4 days in the hospital, less if it's a laparoscopic procedure. And this basically shows that if we have somebody that presents with initially unresectable disease, we can give systemic chemotherapy and still provide, if they have good shrinkage of the tumor, a really good chance of cure. Now, we're not talking about Certix beads. We have Andy over here is going to talk about that, which has added a completely different dimension to the care of these patients. The other things that we can do now, before we operate on patients, if we have somebody that's marginally resectable, either because so many tumors or size of the tumors or location of the tumor, we can reduce the tumor either with chemotherapy or the Certix beads. We can increase the hepatic reserve. Well, how can we do that? You remember I said there were 2 blood supplies to the liver, an artery or a vein. Well, we can increase so if we have the radiologist, like Dr. Lucian, inject the portal vein that goes to the right side of the liver before surgery, 3 weeks. That right side of the liver, then if we embolize it, meaning cut that part of the blood supply, the right side of the liver gets smaller. The left side of the liver gets bigger in compensation for that. So we can then go out and take out the right lobe of the liver and have way more left lobe of the liver than we would have had. So increasing the capacity of the remnant liver. Is that clear? Yeah. So anyway, compensatory hypertrophy, so you can, if you have somebody you're going to be taking out close to 80%, you can increase that, the remnant liver to 40%. So you've got a big wide margin now as far as what you can get away with surgically. Bottom line is chemotherapy, we do a lot of upfront chemotherapy and if in patients that are marginally resectable, and it can convert many of these patients to resectable and thus potentially curable patients. advantages of the chemotherapy. It allows time for to see if there's cancer showing up anywhere else. The disadvantages, they may progress to unresectable status. That's very uncommon. There are some, it does increase the potential for having liver issues, and in fact, from a point of view of the patient being able to tolerate the resection, a lot of times in patients that we're going to be doing a bigger section, meaning taking 70% of the liver or so, and they've had chemotherapy, we'll do the portal venous embolization up front just to give us a little wiggle room as far as the amount of liver function that we have. And the response may hinder finding of all sites of metastatic disease. I think that what we really see in this is we see a fair number of folks that will come in with multiple liver lesions. We'll give them chemotherapy, and we'll have at least radiographic complete resolution. Now, even if you have resolution of the lesions on CT scan, and then you resect that area that was there, you know it was there, you'll still find residual cancer cells in there. So it doesn't mean you completely eradicated it, but you shrunk it down. Probably the end result is if you have somebody that responds, it increases your cure rate. That's the bottom line, because you take out tiny little cells elsewhere, completely wipe them out, and you can take the cells out, or the areas that you can see on the x-ray. I don't know, a lot of theory, probably more than y'all want to hear. For example, what do you do with this patient? We'll show some slides. Patient that presents with colon cancer and has synchronous metastasis, big lesion. This is a CAT scan, uses x-ray and computer. Have y'all seen these? Basically, x-ray and computer to cut you into slices like you're a sausage. So you're sitting in there, your head's up here, your feet are down here, right side, left side. So we're looking up at you from below. Well, this is your backbone here, spinal cord here, front, back, right side, left side. This is your liver, spleen, right kidney, left kidney. And anyway, the dividing line between the liver, the two lobes, the left and the right lobe, is the gallbladder. It's called Cantley's line, the gallbladder to the vena cava. So this is right lobe of liver here and over here. So these dark areas are going to be metastasis. This is normal liver. PET scan, no extrahepatic disease. Need for a biopsy, it was obtained. You probably don't need one in that setting. You have a PET scan that lights up. It's something that looks like a liver metastasis. You do a colonoscopy, no other lesions, so you could either treat the patient with surgical therapy or give neoadjuvant therapy. There's a lot of controversy, even within the surgical oncology field. Many people would operate on this patient up front. Other physicians would give chemotherapy up front. As I recall, we gave this patient chemotherapy up front. And they had good reduction of the tumor size. And then you can see, remember how much bigger this was over here. And then we went in and did the right hepatic lobectomy on that patient. There were just 2 lesions, margins negative, and then the whole question is, do you give any other therapy? Really, the data is really sparse. But at this point in time, this patient has probably a 40 to 50% chance of being cured. They had a dramatic response to chemotherapy and tolerated the operation and did well. Again, this is the portal vein, hepatic portal venous embolization. You know, I will say, interestingly, about dealing with patients with either primary liver tumors or metastatic liver tumors, it takes a village. It is not we have a conference every week. We discuss these patients, and it takes good critical care people, good intensivists, good interventional radiologists, good radiation therapists, radiation oncologists, and medical oncologists. And we present patients with these problems every week and work through them as a team, and then come up with a treatment plan. For instance, this is a young lady that we just treated. She presented with what 5 years ago we would have considered unresectable disease. She had cancer in both lobes of the liver. Again, this is just different areas where they're cutting through the liver, but this is your left side, right side, front, back. This is the liver right here. This would be what we call Cantley's line, right lobe over here, left lobe over here, but she has bilobar disease. Well, generally 5 years ago or 10 years ago, we'd have considered that unresectable. This patient, she received systemic chemotherapy, and then we went in and did a right hepatic lobectomy. We waited for 5 weeks. What happened in that 5-week period of time? Well, the left lobe got bigger. and then we came in and took out the left lobe. So we left her with this little center portion of the liver, which the liver had been, during that period of time, had time to regenerate and hypertrophy. So we were able to take out, probably 85% of her liver in 2-staged operations. And then the other option that we have that's also surgical therapy is radiofrequency ablation or microwave ablation, where we basically stick something that looks like a umbrella in the liver, and we cook the tumor. This is usually in the setting of unresectable disease, or you have somebody, you have a right lobe liver or right or left lobe liver lesion, and you can take out half the liver and you have one little spot or something on the right, and you can burn that as opposed to resect it. Some patients also have too many areas spread throughout the liver to take out surgically, much like the last patient, but they aren't a candidate for stage resection, and you can do radiofrequency ablation on that. So that's it. I think the bottom line is the best treatment is surgical resection. From a surgical perspective, I guess the whole saying, if you go to a barber, you get a haircut. We think that your best chance of cure is with surgical resection. RFA is a nice adjunct in addition to surgery. So I think that's about all for today.
Can I just raise an issue that I'll have you speak to? Many times when I see patients for liver-directed treatment, they've not seen a surgical oncologist, nor have they seen a hepatic or liver surgeon. And they may have had very well-intentioned surgeons at home that have taken their colon out and said, that's all you can have. I'm a big believer in not speaking for another specialty. So maybe just comment on some of the things they should look for in finding that someone to give them an opinion on their liver for surgery.
Well, I think that certainly, like most anything else you do, I think exposure to the problem makes you better at it. So I think that myself and my partner, Dr. Gear, we both treat a lot of liver cancer. I did 2 resections last week, one of them laparoscopically, one of them open. And I think that you need to go someplace where there is an interest in the disease process. I think it's also very helpful to go someplace where you have a multimodality approach. For instance, at conference this week, Andy had a patient that was referred to him for Certex bead treatment. He presented at conference, and it was obviously a very resectable lesion in a young man. The patient was referred from way out of town to see Dr. Kennedy. He presented at conference, and I think we all agreed that the best treatment on this patient would be surgical resection. So, and it works both ways. Many of the patients that I will see that for whatever reason are unresectable refer to either the medical oncology up front or to Dr. Kennedy for the radioactive beads, the Certex beads. So it's very helpful. You want to go someplace where there's an interest and a group interest, and you want your surgeon to be doing this regularly because you can get into problems. It's not particularly simple.